So what I'm going to talk about is the safety, the accuracy, and the side effects of different presbyopic correction modalities. And I'm going to show you how I concluded that PRESBYOND was the thing that I was going to have in my eyes. So my vision, when I was 17 years old, I was plano, 20/10 in each eye. I could see the veins on the wing of a fly at 30 meters. It was amazing. And when I got a little bit older, I was refracted again. I had an eye exam, and again, I was working at Club Med as a saxophone player in the summer during the medical school summers. And again, my vision was very sharp, and this was very useful from the saxophone, from the music stand, to be able to see the audience. By the time I was 43, I had myopicized a little bit, but I was still able to see pretty much 20/10. It was a slightly blurrier 20/10. And when I was re-refracted at 49, I was a little bit more myopic, and now I'd lost a couple of lines of my uncorrected distance visual acuity. By the time I became 53, my vision was 20/32, which is legal driving. I wasn't wearing glasses for anything except driving at night in the rain, or if I needed to see road signs, I didn't know where I was going. But essentially I wasn't wearing glasses because I could see small print in dim lighting, and I could drive without glasses. I mean, I was an average member of the public. I was driving standard. So I get to 53, and now I'm starting to go on a vacation to Kenya and safari, and I noticed that the whole trip I used my distance glasses for driving at night with sunglasses on top because I wanted to see the animals a little bit more contrast. And then I said, you know what? That's enough. I can read, but I want my distance back. So then I started considering whether I could do it with glasses, and I thought, well, no, maybe I could just become younger. And Photoshop, it's very easy to do this, but obviously that's not an option. And, you know, restoration of accommodation is still not an option, so that's not an option. And I want to be very clear here. We have full facilities for cataract surgery, and we do cataract surgery, and we use high-quality diffractive multifocal lenses in our practice. So I want to be very clear that I have any option open to me at zero cost. So cost is not an issue. The challenge of presbyopia is that we're trying to get clear distance, intermediate, and near, maintain optical quality, safety, contrast sensitivity, night vision. We need to maintain binocularity. We have to have a tolerance to the procedure. It has to be a short adaptation time. There has to be simultaneous correction of the refractive error that's present there. And we'd like it to be something that's reversible if it doesn't work, or repairable if a complication occurs. So this is actually quite a long list of requirements. And of course, the ideal solution, as Glenn just showed you, is to give us 3 diopters of depth of field, which we've lost. 3 diopters is all we need. And we try and do it in both eyes. And multifocal solutions have tried to do this. But the trend in presbyopia correction for the last 15 years has been analyzed. And you will now see what has been happening. The full multifocality camp, starting with the array lens, was distance and near in each eye. We all know that the tolerance to this was poor, and over the years, the amount of multifocality has been reduced by the companies responding to the poor tolerance in the market. On the other hand, we know that monovision is a very old method of correcting presbyopia, but we also know that reduced monovision is the trend for monovision. You don't just do a monovision contract trial, and if they don't tolerate, that's it. You now reduce it and find what the tolerance is and give them whatever they can get. So reduction of monovision is the trend on the monovision camp. And you have to understand that the world is divided into these 2 camps. The world is divided into the camp of 2 images or 3 images in one eye, intraocular rivalry of 2 or 3 images, or interocular rivalry between 2 different images. That's the world, that's the 2 solutions at the moment. These are static solutions trying to replace the loss of a dynamic process called accommodation. We don't have a replacement for the dynamic process. And what we've learned is that both camps are now reaching the same conclusion. The only thing we can do with a static solution is to use a micro monovision and use an extended depth of field. And I will prove this to you because I will show you that I'll give you two examples, which are beautiful examples in the commercial space that are open and public, where we show that the reduced multifocality in IOLs and in cornea, multifocality has improved safety and tolerance, and the increase in depth of field from spherical aberration on monovision has maximized the range of vision of modified monovision. So let's look at monovision. Of course, Glenn's just gone over the disadvantages of monovision: blurred intermediate, anisotropia not tolerated, poor distance vision in the near eye, loss of binocular distance vision, loss of stereo. And I actually did a monovision trial, and I found that with minus 0.175, I actually had to take the lenses out after a few hours. I was there was no way I could wear that for a week to see if I can tolerate it. It was just too much. But interestingly, when I put minus 150 in, I noticed it, but I could spend a week like that. I was okay. I could tolerate it. So even that little quarter made a difference in my own brain. So I had what is called minimum cross blur with the plus 150 test. So for me, it was clear that I'm going to use, because the industry has gone in this direction, I'm going to use a micro monovision with an extended depth of field solution. Somehow, that is what I'm going to do. And let's look at this, because you've just seen that the results from corneal refractive surgery are extremely accurate and are second to no other intraocular procedure. Second to none. And the safety is second to none. And the contrast is second to none in terms of multifocality. And therefore, in the multifocal system, where, as John Marshall said, multifocality attempts to substitute the loss of a dynamic system with a static system, corneal multifocality has been proven to be a bad option. The very first PresbyMax, it was called Presby LASIK, had 20 to 50% loss of 2 lines of best corrected visual acuity. This is a recent review of all of the multifocal corneal studies. You see that the safety is very poor. The contrast, when it is measured, is decreased. Even the studies that had good safety had low efficacy. And the best safety efficacy was a combination of 2 studies, 80%, 80%. Let's look at corneal multifocality, because the PresbyMax is a beautiful example of what happened. Initially, the target was both eyes minus 0.5, and the add in the center of the cornea was 225. Yes, they got good near vision, but they were unhappy with their night vision, and there was a lot of loss of lines. 12% loss of 2 lines, not acceptable. Here's another study showing 3 to 8% depending on different parameters. So what did they do? They reduced the multifocality and they introduced a micro monovision. So the target now was minus 0.12 and minus 0.88. The add was reduced from 225 to 175. Same add in both eyes. And the safety improved from 12% loss 2 lines to 5% loss of 2 lines. Okay, this wasn't quite good enough because LASIK is much safer, and so is intraocular lens surgery of any kind. So they reduced it to what's now called PresbyMax Hybrid. And now the add in the distance eye is much lower. The add in the near eye is kept at 175. There's a micro monovision. And of course, this increased the safety to no loss of 2 lines. Okay, we have Michael Luger here, his study, where he actually around the same time tried a similar thing, but he had more add in the distance eye, and he had 7% loss of lines. And so binocular, he's now using, we discussed this, and he's now using 165 add in the reading eye. So essentially what you're seeing here is the trend which I'm describing, which is that multifocality is being reduced and a micro monovision is being recruited. And that's the answer. It's the same story with IOLs. You know, 5 out of 6 patients are extremely happy with their multifocal IOLs. It's true. Full multifocality is beautiful, demonstrated how this has happened with the Tecnis family. The plus 4 lens was very quickly reduced to plus 325 and then plus 275. And why was this? Because of complaints. And what did they find when they reduced the add? They actually got better near vision. Because there was more contrast. So the +4 was a mistake to even start there. You didn't even need the +4. They had better near because of better contrast with less add. And in the FDA study, you see that there was far higher patient satisfaction in the +275 group than the +4 group. But nevertheless, amazingly, there was still a very high incidence of halo and glare, even with the lower add. 30, 40 to 50% halos reported in the FDA study. And these are cataract patients, right? These were not lens exchange. These are patients who started with low transmission, and their transmission went up to whatever the multifocal was delivering. And we know that the multifocal lenses reduce contrast compared to the monofocal lenses. We know that the patient satisfaction is higher in visual quality with monofocal lenses. This is all history. And of course, now the Tecnis family includes the Symphony. And the Symphony is supposed to be an extended depth of field lens. And, well, they're selling it hard in Europe. In fact, they're not even selling the other lenses in Europe anymore. This is the European website. If you click to the United States website, they're not able to sell the Symphony, so they're only selling the multifocals. So what Abbott has demonstrated is they have abandoned multifocality. Abbott have abandoned multifocality. They're not selling the lenses, they're not marketing them outside of the United States because they can. Now, just by the way, Gattinel just published this paper last month showing that at 2 millimeters, the Symphony is a depth of field increaser, but at 3 millimeters, it's a bifocal, and at 3.75 millimeters, it's a bifocal. So it's not an extended depth of field lens. In fact, it's not really an extended depth of field lens. It's a diffractive extended depth of field lens. Now, finally, let's just talk about the target population, because I'm 53. I mean, are these two populations the same? Light transmission. If you have a healthy lens or a cataract, and your best multifocal transmission is going to be 85%, the Zeiss trifocal, you can increase someone's transmission to 85% if they have a low transmission. But if you start with a healthy lens, you are decreasing their transmission to 85%. And of course, with age, this is the differentiator. Obviously, there's no question that an elderly person who has very dense cataract will be extremely happy when you increase their transmission. It's not the same for a young person. And of course, remember, going inside the eye carries these very low but possible introduction of catastrophic risks. And not so catastrophic, but visually compromising risks. So, and if I was to have chosen a accommodative or multifocal or bifocal or trifocal or diffractive lens, I had to consider that this lens was going to have to live in my eye hopefully for another 40, 50 years. And, I'm active. That's not me, but I'm active. And I might, do my snowboarding and slam my head on the snow, hard-packed snow, and I don't necessarily want to know what an IOL would do if I had a big, fat head trauma deceleration injury to the back of my head. These are active patients, the 50-year-olds. These are not the same as 90-year-olds or 80-year-olds. And so all of these late dislocation complications, and of course time, there is no long-term data on clear lens exchange in 50 to 60-year-olds. There's no data published in the literature. None. So we don't know whether something will happen in the future. It is a question. So finally, the answer is extended depth of field in monovision, because that is the way the whole industry is going, and I think it's curtains for multifocality. Just like it's curtains for monovision. So I chose to have blended vision. Yes, I wanted to keep my transmission as high as possible. And I know that my transmission will diminish over time, and I know that I may myopicize again over the next 10 years, but I would take the risk of 3 enhancements before I take the risk of 1 intraocular surgery, with a 20% chance of needing an enhancement by laser because of targeting. If I develop a cataract and my transmission goes way down, no problem. I will put in whatever is the highest quality monofocal IOL with low PCO rate, and my transmission will go back to 100%. And I have the depth of field already in my cornea, placed in my visual axis, on the visual axis, the right amount of spherical aberration. My programming was, I added extra spherical aberration to my distance eye, and is a short little video which you can play for me of, it's 20 seconds, showing the process that I went under. As you can see, programming my case and importing the wavefront data from the WASCA, my eyes, and here we are, there I am, there he is, there we are, and it didn't hurt. It really didn't. I could read the chart. It was actually, it looked like someone filled the room with steam, which is exactly what I say to patients. I was reading the card straight away, because I was reading it before, but the only mistake I made was that I sat down on the wrong side of the fortunately, the camera was still running, and we decided not to edit that out, but it's a sort of reflex reaction, so Glenn had to check me. So for me, instead of wearing glasses, I chose to have PRESBYOND for my eyes, and now I feel the same as I did when I was 21, Geo at Club Med playing the saxophone. Except I'm not at Club Med and I only play the saxophone once a month, but I'm 20/10, my intermediate vision is J3, and my near at 27 centimeters is J1. Thank you very much.